Manfred, hello.
Hi,
Can you hear
Katya.
me?
How are you?
Can you
Good.
hear me
Yeah, I can
well?
hear you. I can hear you well. How are you?
Good. I'm fine,
Great.
thank you. Yes. So,
Right.
hello from Ukraine. And we start with the monkeypox. And to start with, I would like to ask you about all the differences between different poxes. Monkeypox, natural pox, chicken pox. So what's the difference? Are they all similar or not? And how monkeypox differs from them?
Okay. So first of all, I think thank you, Katya, and thank you to all of you. I need to make it very clear that the word pox doesn't mean that they are the same viruses or even the same family. So chicken pox is a completely different virus. It's a family of the herpes viruses. So it has it's not even a close or even a distant relative of the other pox viruses like smallpox. Monkeypox and camelpox, those are related to smallpox. They're the same family. So they're the orthopoxviruses, and they are all in the same family, but they differ in the way in which they affect. Smallpox is actually only affects humans. It doesn't affect animals at all. And that's in fact the reason why we managed to eradicate smallpox. However, there are other pox viruses related, and one of them is monkeypox. Another one, for example, would be camelpox. So we're talking specifically today about monkeypox. And monkeypox is basically a disease of monkeys, but it can transmit to humans, unusually, but it does occasionally, usually being seen in Africa, mainly in Central Africa, now in West Africa, but it does occur occasionally outside of Africa, usually when people import small animals as pets and they are infected and you get from contact. It's a much milder disease than smallpox, by the way. So first of all, we're talking about a disease that doesn't have the same impact, nearly the same impact as smallpox. Smallpox has maybe about 30% mortality or case fatality. Monkeypox in humans has virtually no case fatality. There are very few deaths from monkeypox.
So do we have now a threat of new pandemic, and how threatening in general is monkeypox?
Well, this is certainly a very unusual event and something as we are very unexpected, because as I said, usually monkeypox has been transmitted from animals to humans, but in small groups, and in Central Africa it's been really much more common, but still hasn't really spread very much outside, and it's really through contact with animals. The monkeypox that we're seeing now is actually related to the virus, the monkeypox virus from West Africa, which fortunately causes a less severe disease. But it spread in a very unusual manner and very unexpected. It seems to have started primarily among groups of men who have sex with men. In Europe, there were gatherings where the peeps, presumably, I mean, definitely there were people who had been infected by monkeypox in Africa, had come to these gatherings, and then through very close contact with others, started to spread it amongst others. It spread primarily through very close contact. So sexual contact clearly would be very close contact. So partly through body fluids, partly direct contact, body fluids, and maybe there may be some aerosol spread. We still don't quite understand it. So generally speaking, you require very close contact. You need close contact generally with the lesions that are caused by monkeypox.
So is it spreading now widely through other countries, not outside of Africa, for example, in Europe, or is it spreading in Israel? And if yes, then how?
Well, this is the interesting part. It spread very rapidly. Even though it's still within that same high-risk group, it's, for example, there are almost no women affected that we know of. and it's almost all people who have reported themselves having sex, men with men, but it's spread very rapidly. So if you follow the epidemic curve, if you follow the spread, it was an exponential spread. In other words, the doubling time, every couple of weeks, the number of cases doubled. And we've reached, going from just a few hundred cases initially. Now, the last report was about something around 53,000 cases in the world, in 75 countries. And in Israel, we've had a couple of hundred cases, right?
If we speak about the disease itself, how dangerous is the disease, or is it a very mild disease?
Well, the disease, it depends what the incubation period, we believe is between 5 and 21 days. And it usually lasts between 2 and 4 weeks. And it's usually skin lesions. And again, probably due to the sexual contact, many of the skin lesions have been actually in the genital area, but also in other parts of the body. Clearly, the lesions are they're painful, they're not, or sometimes can be painful, they can be infected, and they leave scarring. One of the real problems, other than the major impact of smallpox generally, in terms of death and so on, was also to leave scarring, and people would be scarred on the face, and these are often very deep scars. So the scarring that's really the main issue here. Having a period of time where you have a fever and a general kind of viral illness, and then with these lesions coming up and leaving large scars or relatively deep scars. But other than that, there's virtually been no deaths. There've virtually been 2 or half a dozen maybe deaths that have been reported. So in that sense, it's not dangerous in that sense, but it's clearly very uncomfortable.
Is it a dangerous disease for those who have HIV/AIDS, or it's not clear yet?
Well, it could be, because a large percentage of the people infected in the epidemiological reports, the studies, the investigation, have shown that a relatively high number of the people infected are HIV positive. So I guess that HIV may certainly be predisposed to monkeypox, but that I think is still being investigated. I'm talking just about the epidemiologic data. Still need to look at the mechanism.
You said that it's reported in 75 countries. Do I understand correct that depending on the development of the country, democracy which exists in the country, attitude to men having sex with men, some countries might never report it in a way that we don't have men who have sex with men, that's why we do not never report this disease, or the men would never go and complain about any kind of symptoms?
Right, so that's a very good point, and I have to be very careful about what I say so that it's like politically correct. For example, if you look at the reports from the world, I mean, we've seen very high numbers in Europe, the United States, Canada, UK, France, Germany, those countries. They're reporting very high numbers, thousands of cases. Interestingly enough, a country like China has reported, the last report that I saw has reported only 3 cases. So this is unusual in the sense that you would expect a disease that's spreading so widely to get a country that has a very large population. India has reported a number of cases, but not, it's increasing, but again, it doesn't seem to be increasing as rapidly as we've seen in the European countries. So I guess it's partly related to behavior, but it's certainly related to behavior, and it could well be cultural in the terms of behavior. But the other aspect would be cultural in the sense of actually having speaking about it, and actually there's nothing cultural about men having sex with men is probably the same anywhere in the world. But the other point would be that there may be much less reporting. As you're right, there may be a lack of willingness to report because it's so common, it's primarily in a high-risk group, which tends to be stigmatized.
Mm-hmm. What about vaccines? Which vaccines are used for this disease, and were they invented recently, or this was some old vaccine which fit to this disease? So what do we know about the vaccines for the moment?
Okay, so primarily, generally for viral diseases, we have this, vaccines that are very specific for the actual disease. But interestingly enough, even the smallpox vaccine that we use is not actually based on the smallpox virus. It's based on the vaccinia virus, which was probably related to the cow, regional cow virus that was the basis of the initial vaccines. So we are using for smallpox a vaccine that's based on a vaccinia virus. And that virus seems to produce antibodies that are protective against other pox viruses in the orthopox family, such as monkeypox and camelpox. So the vaccines that are recommended at the moment are basically the smallpox vaccines. The main one that's recommended at the moment is the one that's being produced in Denmark, and it's actually based on the name of the company. It's called MVABN. So it's actually a modified vaccinia ankara. So it's a vaccinia virus. In other words, the same kind of virus we use for the vaccine strain, but it's been modified so that it doesn't replicate. And in that sense, it won't spread to other people. Because one of the problems with the smallpox vaccine, the general vaccine, is that you can infect other people if you've been vaccinated. So that is the one that's being recommended now. And the name, it has some complicated names. It's called Jynneos in the United States, and in Europe it's called, I think, Invoimmune and Invomex. So it has different names, but it's basically the one that's produced in the facility in Denmark. The other vaccine is this general, what we call a CAM 2000, which is based on dry vaccine. That's it's based on the original vaccinia virus. It's replicating, but it may be more effective, in fact, against smallpox, but it has the disadvantage that it's replicating, which means that if you've been vaccinated, you can actually spread that vaccine virus to other people, and it could impact then on immune deficient people.
How many doses are used to get protection against the monkeypox, or we still do not know what is the effective dose administration?
Right, we're in this strange situation where we're using a vaccine where there's never been a randomized controlled trial. So it's not a vaccine that's been tested in a trial. And we really, the best information we have is information on animal models. And obviously that's a problem. So we really don't know very well how the dosage should be. Some countries have, I think France has recommended that you give one dose to people who are at high risk, and then if they don't get infected, you can then give a second dose sometime later. But it's not really clear to what extent one dose is protective. We hope that it is. And so there's a kind of debate about whether you need one or two doses, basically.
Are we speaking about the preventive vaccination or post-contact vaccination?
Right, you're quite right, because for smallpox we would often give the vaccine post-contact. From the smallpox history, and again it's based on observational studies, not that and very few, we've assumed that within a few days of contact you can still be protected by vaccine. So we believe like in 3 to 4 days from the time of contact or infection, you could still be protected by the vaccine. You would have to guess that may be true with monkeypox here, but I think primarily the idea here is to spread to potential contacts, although clearly anyone who has been in contact could get a vaccine, and then either because they've been in contact or because they're in a high-risk group anyway. So they would then be protected again by further contact. But we still don't have good data as to how protective it is against in people who have already been infected. In other words, they've already had contact. Does this vaccine actually modify the disease? The smallpox model is generally that if it's given within the first 3 or 4 days, it would modify the disease and make it a much milder disease.
What is the strategy of the vaccination against the monkeypox in Israel for the moment? And is this vaccine allowed as off-label use, or is it a clinical trial considered to be a certain stage of a clinical trial? So whom are you vaccinating, when, how, and what is the justification for use of the vaccine if there were no clinical trials?
Right, no, it's under emergency use, so the approval is emergency use. It's not approved generally, but emergency use, as we've done with the corona vaccines, with the COVID vaccines, which are also under emergency use approval. So that should not be a major problem. The policy, again, in Israel is still being developed. Again, if someone has been in contact or is at very high risk of a further contact, these people would be offered, but there's still not clear indications as to who exactly should receive the vaccine. We're still developing a policy there, but we have purchased a supply of vaccines. So, but again, it's a limited supply. There's not that the supply of the modified one. There is a worldwide supply of smallpox vaccine for the whole world, but the modified one that's being produced in Denmark, that is a non-replicated, there's a very small supply, a few million doses, and so countries are buying up for themselves. So it's not going to be for very widespread use.
So you procured it, but you didn't start using it yet, or you did in the country?
We've started, but at a very limited scale. Just the beginning, right?
So the question is, how, in your experience, because you obviously saw many campaigns of different vaccination campaigns against different diseases, when you have the target group, which is basically very specific group of men having sex with other men, how at all this kind of intervention can be built? I mean, basically, what can be the messaging in this case? If you are, having sex with other men, you then should get the disease. Or if you are a faithful partner, you shouldn't get the disease. Or at all, how to communicate such a campaign when it's not about all the people, but just of one group of people with certain, so to say, lifestyle.
The messaging is very complicated in this situation, as you've described. First of all, we did have a debate as to whether we should first vaccinate healthcare workers who may come into contact with them, and then vaccinate the higher risk. But if you look at the figures, the chances of a healthcare worker being infected are very, very low. I mean, they would, as I say, you need direct contact, and there may be some airborne spread, but it's probably very limited. So the number of people, the number of healthcare workers who've been infected and are not part of the high-risk group themselves, in other words, they're not infected by their work, is probably very, very, very small, very small. So although initially people said, let's use the small supply first for the healthcare workers, on the other hand, we said, no, let's first give it to the high risk. And then you get to exactly to this point. How do you actually get to that community? Because this is a community who are already, to some extent, or to a large extent, stigmatized. In other words, they are going to have to identify themselves as being men who have sex with men. In other words, are you going to say to somebody, prove to me that you are in the high-risk group when they come to get the vaccine? So basically, you are relying entirely on somebody coming and saying, I want the vaccine. It's going to be very difficult to then say, I need to ask you some questions and see whether you fit the group. So you would depend really on messages through the high-risk groups and rely on these people. So at the moment, the message, I think, to the general community is that we've identified high-risk groups as men who have sex with men, and if you're not in that very high-risk group, or you're not in contact directly, in other words, sexual contact, particularly with men who have sex with men, because it could be a woman as well, and there have been children who've been affected, then you would say, okay, it's your choice. You know, you really go, and all you do is say you want the vaccine. But you really, it's not going to be easy. And I'm sure that in some countries, it's going to be very difficult because people don't want to be identified. And, you know, at different degrees, it's going to be difficult everywhere. So, you know, I'd be interested to hear how you actually are going to deal with some. If I understand, you have seen very few cases reported actually in Ukraine. I don't see many cases in the global reporting. There have been very few cases. Is that right?
Yes, and I would say I still would perceive there could be a problem with that, in a way that people would not like to speak about it out loud or identify themselves in this situation. And in my view, this is one of the most interesting debates on this. I remember that with the campaign on the human papillomavirus vaccine, it was raised the first time that you have to speak with children about sex if you want to really explain them what this vaccine is for. And in some countries it was not so easy to convince parents that they would still have to speak to even teenagers about sex. So in this particular case with monkeypox, it's getting even more complicated, I would say, for different countries and different cultures. Just wanted to ask you, in terms of coming back to the question whether it's a big threat or not. So do I understand correct that if it remains for the moment as a quite mild disease, which is not spreading so much unless you have the close contact, it's okay, but if it will change somehow to stronger airborne or anything else, it will become a very serious threat or not?
I think that's what would worry me most of all. We don't have any experience really. What we're really looking at is a new phenomenon. And it's a new phenomenon because this is a real emerging infectious disease, or you can call it re-emerging if you like, but because we've seen it before, but we've never seen it at this scale, and we've never seen it spread at this level. And again, you know, I'm talking with many of you in the audience are specialists, those who know infectious diseases, viruses particularly, bacteria as well, but can do nasty things, as we've seen with the coronavirus. So if this virus is spreading widely in humans, and it's not the natural hosts because it comes from animals, it would, although the smallpox virus has been very stable, and generally it doesn't mutate much, but we don't know whether this virus might start to mutate and both become more infectious, and or even worse, start to produce much more severe disease, because it's in a family of viruses that can cause very severe disease. So, you know, so what we do, we need to have a very close hold on the topic. We need to do everything we can to control it at this level when we can still do it. And again, we'll go back to your messaging. I'll just mention one thing when we go back to messaging. I was told when I speak to the media not to call it a sexually transmitted disease. And there's been a discussion in well, that's a problem when you actually look at it, because the real definition of a sexually transmitted disease is that it's transmitted by fluids, by sexual fluids, but this is primarily has been the result of sexual contact, as we understand. So I think that we are avoiding the message that should go through, that this is primarily through sexual contact. But I must again repeat, I was asked not to emphasize that too much. So it's a complicated issue, but we need to be very careful. This disease could get out of hand. It could become a major problem.
Speaking about the surveillance and the diagnosis of this disease, for the moment, how the diagnosis is confirmed, and are there surveillance systems, or it's mainly just case by case diagnosis is confirmed and verified?
It's pretty much case by case. In the high-risk groups, there have been attempts, I think, to try and get a message through to make sure that you know, and it's again like viral diseases. So the disease would start as a typical flu-like illness. So you would have fever and muscle pain, you know, myalgia, muscle pain, and lymph glands that get swollen, and then you start seeing lesions on the body. They may be small, they may be large. So you depend very much on individual diagnosis. In other words, the individual is knows that they're in a high-risk group, knows that they've been in contact with someone who's had it, and physicians who'll be able to recognize it. And that brings us back again to other diseases that can be similar. Smallpox, you know, there's often this discussion that you can distinguish between smallpox and chickenpox because the rash is different. But here we're not really worried too much about seeing much chickenpox because we see very little chickenpox now since the vaccine has been introduced. But again, I think physicians have to have a high level of suspicion. In other words, somebody who comes with a lesion, and again, the inquiry has to be the sensitive level about sexual behavior. And physicians often avoid asking these questions. So we need to make sure that these are asked. And, you know, this is not something that should be hidden because this is something that's going to get out. You know, we're going to lose control if we don't do it.
Actually, we see a lot of chickenpox in Ukraine, and we have regular outbreaks of chickenpox because this vaccine is used only as the vaccine of private market when people are willing to pay and get vaccinated. So chickenpox is still on our agenda very much as outbreaks. Coming back to messaging and campaigns. For example, probably from the HPV campaigning or from any other campaigns. Do I understand correct that in cases when it's about such a small group which is stigmatized often, it is mainly about working through certain opinion leaders within this particular group, or is there any other message delivery system in this situation?
Right. Well, you know, we tend to think of it as a small group, but if the data are correct, it could be anywhere between 3, 4, 5% of the male population. So that's not a small number of people. The messaging again is very similar to HIV or to other sexually transmitted diseases, particularly to avoid having any sexual contact with a new partner or someone. Certainly make sure that if it is a partner, you're someone that does not have lesions and with somebody that you know reasonably well, and not this one time contact where you don't know the person and often not clear whether the person has lesions or not. So it's really, again, going back to, even though we don't like to say sexually transmitted, but it is safe sex. It is having sexual contact with people that, either it's your own partner or it's someone that you've been with for a while, and you, again, limit the number of partners, because there's certainly a much greater danger of infection if you have a number of partners. And this, this is what seems to have happened when there are, I guess, festivals which attract largely MSM or the LGBT community, to make sure there that this doesn't, there's sometimes alcohol and people are not, really very responsible. So these have to be the messages. Very difficult, and I think it's through the opinion leaders, through the leaders of these communities, and in general.
Mm-hmm. Manfred, you disappeared. Just a second, you disappeared from the screen, so we are trying to get you back, but I hear your voice, which is
right.
very nice.
For some reason, there's I see a screen there. Yeah. Are we back? I think we're back. Suddenly there
Oh,
was a
yes,
screen
yes,
sharing
yes,
or something.
yes, we
Right.
are back.
Yeah.
Just one terminological question, and forgive me for my ignorance. When we would, for example, read any kind of material on immunization campaign with regard to this, or any kind of epidemiological article, what would be the difference when we say gay men and men having sex with men? What is the terminological difference between the two?
You know, the terminology keeps changing. And I've often asked some of the people, because I've actually headed a committee here for blood transfusions and what are the conditions for exclusion from blood transfusion. And this was very much an issue for the community of people who are basically men who have sex with men, and because they were limited, and we've removed that restriction. I think MSM is the traditional one now being used. But again, some of them call themselves gay men. I know that I've had students from the US, more women, I think, but who've been using the term queer. And queer used to be a term that was not appropriate. In other words, it was objectionable. In other words, people who were lesbians or homosexuals and did not like that term. And now that term has come back again for some subsects of that. So it's interesting how the terminology changes. I think that MSM is the best term, because MSM doesn't necessarily mean that you are not having sex with women. You could be bisexual. So it means basically that at some time, part of your time, you are actually having sexual contact with men. Men are having sexual contact with men. So I think MSM is, to me, a better terminology.
Again, about adolescence. People start having sex at different age. What is the debate in Israel, and what is the data in Israel with regard when children start or adolescents start to have some sexual life? Because to be able to prevent some diseases, you have to talk to them about sex in general, and as well about that there exist all different kinds of people, like gay people, bisexual people, other people. How this is built in Israel in terms of, I don't know, education system or in culture? Where is this debate for the moment? In terms of HIV, for example, you need it, or hepatitis, or now monkeypox, for example.
It's a very good question, because in fact, I have to be honest, I don't really know much about the initiation of sexual behavior in homosexual adolescents. In other words, male children having sex with other males. So I really don't know to what extent that where that starts. In the heterosexual community, interestingly enough, it seems, at least, actual sexual intercourse seems to be occurring a bit later now than it used to. There's been kind of like a little bit of a reversal. But still, we have to recognize that, once after puberty, pretty much, these kids could be already having sex. So you need to get sexual education into the program very early on. And some argue that it should be, even in the primary school at the age of 8 or 9 and so on. In other words, start to talk about it. And I think that makes sense. But I know that there are some more conservative families or parents who would not like that to be done. And again, we face subgroups who may, again, object to sexual education in young people. I hope that's changing, but this could possibly occur in some religious communities. So that could be an issue as well. So I think all of this is something that we need to work on together.
Let me check the Let me check if we have questions. No. You are actually, as usual, watched very well, so people are really watching you as usual, but we have no questions. What would be your last message in this interview with regard to monkeypox to our colleagues who are watching us for the moment?
I'll make a it's related also to corona. And the reason why I'm saying that is because I think that what happens when new diseases emerge, we tend to deny that they are occurring. When I say we, often not only the public, but even the health authority. It's not so bad, it's going to go away, it's only a small group, it's a small group. And that happened very much, by the way, in HIV when it first came about in the US. It took a long time for the United States to recognize that this was a real problem. And that actually allowed it to spread very widely. There was very little intervention initially, even in the first couple of years. So we need to be very conscious that when we see signs of these new diseases, as we did with corona, and corona we went through the same thing, denying it and saying it's going to go away, it's not so bad, it's just like flu and so on. So again, with monkeypox, we have to say, look, this is a new disease, or at least a re-emerging disease. We need to take this very seriously and do everything we can now to monitor it, to educate, as you said, to educate very carefully and try and control it, make sure that we have vaccines in place, and put together a very good organized vaccination policy, and then have this working very early in the outbreak, not waiting to see if it's going to get worse. Because I've noticed that in a couple of cases now, and I see, I've forgotten, one of the countries, I think even Germany, are now limiting their purchase, or India, I don't know, one of the countries, they're starting to say, well, maybe we don't have to purchase too many vaccine doses because it seems to be that the disease is going away. That can really be an illusion. These are diseases that will come one wave and then it'll drop and then we'll see another wave. So I would say we need to be very, very focused on this monkeypox.
Thank you very much, Manfred. Thank you very much for everybody who was watching us. Буде доступно це відео також англійською мовою, і можна буде дивитись в перекладі, і можна буде дивитись в оригіналі англійською. What I am saying that you will be in two versions, in English version, original, and you are for the moment in translation for those who are watching this today. Thank you so much.
Okay, love from Dorit, and again, good luck, and just do. I told you before how much I admire you people in Ukraine, and we're all with you. You're fighting a terrible enemy, and you have to get rid of him. And
thank you, Manfred.
We want you to win as soon as possible.
Thank you, Manfred. So see you soon, hopefully, with a new topic.
Okay. All the best.
All the best.
Bye.